Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith Rogers, producer of Public Health on Call. Today, the role of social media in health communication. I speak with Jessica Malaty Rivera, an infectious disease epidemiologist and senior science communication advisor with the de Beaumont Foundation. She's also a doctoral student at the Johns Hopkins Bloomberg School of Public Health and Health Security and a public health influencer with more than 430,000 Instagram followers. Let's listen. Jessica Malaty Rivera, thank you so much for joining us on Public Health on Call. How are you?
I'm good. Thanks so much for having me.
Good. It is a delight to see you. And for those of you that are listening, we are actually doing this podcast together in the studio, and it's really fun to be in physically the same space. For those that don't know you, would you give us a little bit of a background?
Sure. So I am Jessica Malaty Rivera. I'm an infectious disease epidemiologist by training, and I've been in the science communication space for about 2 decades. I'm also a third-year DrPH student at Johns Hopkins in the health security track, where I am studying trust and misinformation and online ecosystems, information ecosystems, that is. I'm also a researcher in the Center for Health Security.
That's really what we want to talk about today is we're going to kind of peel back or open the box and see what's going on online. A lot of our conversations tend to be about how can we be better communicators? How can we be breaking through the noise? But today we're actually going to look at what the noise is. You've been working in these online spaces for a long time. Let's start with something like, for example, how people are engaging with social media in their lives when it comes to their own health. What kinds of things are you seeing?
Yeah. I've been in the space for quite a while, and I've been on the social media side of it for at least the last 6 years in a more significant role. And it is a primary news source for a lot of people, and it's not just traditional news. It is health information, it's political information, it's nutritional information, it's parenting information, and everything in between. And because of that, you've seen a lot of traditional news sources and influencers treat this as the way to get their content out, whether it's through short-form videos or infographics or carousels of photos. It is truly an incredibly loud space that is full of a ton of content. In the health space, it was a critical mechanism for disseminating information throughout the COVID-19 pandemic. A lot of the public health agencies used it to inform the public, and groups like the COVID Tracking Project, which I helped lead, used social media every single day to just, to share all the data that we were collecting. And since then, it's kind of evolved into a very, very noisy space. It was loud, and now it's noisy because there's a lot of different types of messengers that have risen to the top as far as the loudest and most influential.
How do people get heard in this space? So you're dealing with an algorithm, you're dealing with a lot of content creators all trying to get eyeballs. What are some of the things that you're seeing of how people are actually getting their content out there?
Yeah. The algorithm is not static. It is constantly evolving, and it has changed a lot in the last several years. There was a time when the algorithms were in favor of very science-forward and evidence-based content because we were in the middle of a public health emergency. I remember being, front-loaded to a lot of people's For You pages so that they could see my content. I remember there being lots of banners and saying, if you want to find health information, please check out the CDC, WHO. There was a time when that existed. Over time, as a lot of these platforms have now graded health information as political information and thereby deprioritizing political information, our content gets deprioritized. It's a lot harder to kind of beat the algorithm in that sense and end up in people's feeds. Public health content is not as salacious as headline news and doesn't get the types of clicks and eyeballs that the algorithms prioritize. And so as a result, we don't see as much engagement as we would like. It's not to say that there isn't any, but it's required us to kind of pivot multiple times to figure out how to play the algo game.
Yeah, and so not only are we sort of fighting for that eyeball space, we're also competing against content that is rapidly being amplified because it is false or it is in some way
like inflammatory.
Yeah. How have you seen kind of the erosion of checks and balances and, third-party auditors? How has that influenced this as well?
This is another byproduct of the deprioritization of political content because there was this big existential conversation. Part of it was because the government inquired about this type of moderation, content moderation, that these platforms really wanted to take a step back from the role of being arbiters of truth, which was not really the task we were asking for. We wanted to have the checks and balances, as you mentioned, to at least be able to flag content that was categorically false, that was demonstrably harmful to people if it was unchecked. And unfortunately, that doesn't exist anymore. I mean, there are some checks and balances for extreme types of content, but the type of categories that existed 6 years ago of us being like, this is false health information, this is false health information about COVID-19, that's all gone. And it's sad because it then puts the burden on the content itself to either be true or to have to be corrected if it's not.
Or on the user, right?
Right.
There's a literacy piece here.
Yes, exactly. And I would say that because of this oversaturation of information, some people would describe this as an infodemic, which is just so much information, not just bad information, not just mis and disinformation, just so much. It makes it really hard to be oriented on the internet and know what is true and what is trustworthy. It's very difficult even for folks like myself who are chronically online and have to kind of parse through all of this to say, where did this even come from? And how can I figure out if it's going to be really harmful or if it's just this weird fluke that just kind of slipped through the algorithm?
Yeah, and actually, I want to dig into that a little bit with some specifics. So, the average person, kind of has their echo chamber, like the algorithm has been shaped around what it thinks they want to see. So how are these online spaces kind of shaping people's perceptions of health risk? What does that look like?
Oh my gosh, this is such an important conversation because risk in general is such a difficult thing to communicate about, and humans are not really good at assessing it. I mean, that is beyond just health. There's a lot of confusion about risk versus hazard, right? A hazard is a thing that can cause the harm. A risk is the likelihood of your exposure to it. So you need the exposure to the hazard for it to be actually a problem. And that distinction is really difficult. Risk is also extremely personal. It's very subjective based on your family, based on your health history, based on where you live. And a lot of information right now, because of the lack of context and nuance to distinguish between things like risk and hazard, make people feel like everything is a hazard and everything is going to cause them harm. This is especially true with nutritional information. And I think, in the most recent context of the release of the dietary guidelines, people have been really, I think, preyed upon in understanding what is healthy, what is nutritious, what is toxic, what is not toxic. There's lots of content right now that create these false equivalents of comparing these ingredients to these ingredients, or even saying things like this ingredient is in that, and therefore it must be bad. Like one example that comes to mind is there was a whole trend, this whole viral meme of this ingredient that's in this type of food is also in yoga mats. And you're like, okay, well, baking soda isn't a fire extinguisher. Does that mean I'm not going to eat cake? No. But again, it's the context, the nuance, the why do we have all these even regulations that will protect humans, protect the population in the United States specifically, to understand things like toxicity and dose. I feel like I'm constantly repeating myself on the internet and reminding folks that this may seem like a, five alarm fire. Yeah, I'm really bad at idioms. This might feel like a 5-alarm fire, but really it's just something that is missing some context. And I think that actually helps a lot of people understand how to be better consumers of information. I think that is part of the literacy training of, okay, if this made you feel a certain type of way, how can I take a step back with you and help you understand that your life is not in danger imminently?
So what about the moments where your life might be in danger imminently and you have, let's take this off of the algorithm for a minute, so people are getting kind of told day in, day out, risk, 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 risk. Then what happens when there's an actual emergency and those messages are coming in about how to protect yourself? How does that play out in the real world?
Yeah, this, again, this is what keeps me up at night, because this distortion of risk makes it so that the things that are not actually going to cause imminent harm are occupying people's brain space, and the things that are actually going to cause harm or not, right? So a great example of this is the measles outbreak that's happening right now. It is an extremely acute situation because vaccination rates are going down. It's the most contagious infectious disease that we've ever identified. You know, if one person is infected and there are around 10 people who are unprotected, 90% of those people, 9 out of 10 people will get the measles. That is a very high risk situation. But because of misinformation, because of false information, because of conspiracies, people have perceived it as, well, it's just a rash, or it's just a childhood disease like the chickenpox. And the risk categorization of something that actually is high has been downgraded to something that's very low, and people's tolerance of it is extraordinary. And so part of this is explaining the context of what are the consequences of this thing versus that thing, and what's the likelihood of those consequences happening without being fear-mongering, without causing panic. And I think that's part of like the task of science communication, is communicating a way to compel people to make an informed choice. I'm not telling anybody to do anything. I'm saying, here's the tool for your toolkit. Be empowered to make this choice so that they're not incorrectly assessing risk wrong.
One of the things in science communication that we've heard about is this call for more transparency. And, you know, over the past year, I think there's been a lot more public exposure to policy processes, for example, that before happened in very separate spaces. Like, I think until 2025, a lot of people didn't even know what ACIP was. What are you seeing in the online space as we get more exposure to these kinds of things? And what are maybe some of the pitfalls?
Yeah, I mean, at this point, the cat's out of the bag, and not that it needed to ever be in the bag. It's that COVID-19 has exposed people to a lot of things that were very insular before, that was very kind of niche public health science content. The average person, ACIP was not on their radar. The average person was not watching VRPAC meetings and ACIP meetings. The average person wasn't reading preprints. And now everybody is. There's kind of a familiarity with a lot of public health language and topics. And so we're not going to reel that in for any reason and say like, oh, this should go back to being a very insular thing. Like, I actually love that people now are asking questions about R0 and, you know, vaccine effectiveness, et cetera. I want to explain that because I actually think that's what gives people that empowerment to make really informed public health decisions. When it comes to how people kind of exist with that, I think transparency has been a very, very fraught subject, right? It's caused a lot of people to make a lot of assumptions about who has the power, who has the information, et cetera. It's not that they were never allowed to be watched. It's that people that watched it were just the people who cared. Now everybody cares. And it's also on the front headlines of the New York Times and CNN, et cetera, because they are so consequential right now. And what's happening with this administration is a big shift from what has happened in the past, where it was pretty uneventful in previous years. I actually think getting more people to watch these things is a good thing. Now, at the same time, what is happening in these meetings is concerning, not because of the transparency part, but because it is such a deviation from evidence-based procedures and evidence-based recommendations. That said, I think scientists for a long time have needed to get better at not just saying what they know and not being so certain about it, but also introducing uncertainty to folks and talking about the process of getting to know the answer. I think that's where the MAHA movement has really capitalized on messaging, where they've used a lot of language that makes it sound like they're just asking questions. They just want to do good research. They just want to do gold standard science. And it's made the movement seem altruistic. The problem is a lot of these questions have already been answered, and they're coming in with preconceived kind of answers that we already know are not true. And so it's trying to help people understand, like, look, we are not here squashing curiosity, squashing transparency. We want to make sure that we're actually sticking to the science and the evidence.
And helping people understand what all of these things mean. Like,
yeah.
I mean, you can sit in on any policy meeting, but if you don't have someone kind of explaining to you what's going on and, oh, this is normal, this is not normal, there's no context for it.
Exactly.
So let's also talk a little bit about, you know, certain concepts or phrases that people may have been introduced to in the last year that maybe mean something different in different spaces, depending on where you are. Something like informed consent.
Yeah. Informed consent is a very, very hot topic. It's not a new topic. It has existed for a long time, but it has become kind of a battle cry for a group of folks who believe that it either doesn't happen at all or doesn't happen in a way that they are satisfied with. What essentially informed consent refers to is a patient being told about the risks and the benefits about a treatment, a drug, a vaccine, a medical procedure, anything in between, that they are fully informed and that they agree with their provider that this would be the decision that they are going to go through and accept. A form of informed consent that has existed for many years is the vaccine information statement, which is a document that is legally required to be given to every single person for every single vaccine dose that is ever administered. If the person who's being vaccinated is under the age of 18, those documents are either digitally or physically given to the caregiver or the parent. And it is a form that is created by the CDC that goes through the risks, the benefits, and everything in between. There is a movement now, and we've seen this already happen, to almost rebrand it as something they're calling shared clinical decision-making, which is an extremely obtuse phrase that surveys have shown providers and patients don't know how to define. It sounds good. It sounds sincere. It sounds honest and transparent, and it sounds like somehow better than informed consent. Unfortunately, 25% of Americans who were polled in a study that was done by the Annenberg School thought that it meant that they could just kind of choose whatever they wanted, that everything became optional, almost like that the vaccine schedule had become an a la carte menu. Some people perceived it as, oh, we should be talking to other people around, not just the provider. Some people were also unable to answer who would be the person they should be sharing that clinical decision-making with. Only, half of the folks recognized that it could be not just a doctor, that it could also be a nurse, or that it could even be a pharmacist. And so it's concerning because at the bottom of the text, if you look at the CDC's definition of what this now means, it says something to the effect of it's how the CDC is now justifying the change from a recommendation to SCDM, shared clinical decision-making, when they don't think that a widespread recommendation for an intervention like a vaccine would be beneficial for a population-level recommendation, which is deeply concerning if you look at which vaccines ended up getting shared clinical decision-making. Hepatitis B being one of them. Hepatitis B is probably the perfect example of population-level benefits because we've seen years and years of data that when you have this early intervention with an infant, you reduce the incidence of chronic hepatitis by 90% at a population level. And so this is where I feel like this lexicon war that we're in feels very insincere. It sounds good, but then when you really dig in, it's quite sinister.
So we've got these inflated senses of risk. You have a very noisy atmosphere with not a lot of checks and balances on social media. You've got an algorithm that is just kind of doing what it's doing. And then we have a lot of chaos just happening, politically, socially. What else right now is kind of seeping into our consciousness around these conversations?
Yeah, the concept of trust just feels like the most fought about and strived for thing. The day before there were a lot of changes to the CDC website, I remember looking at the About page that had been updated, and I counted the word trust was mentioned 12 times on one page. It's because it is kind of the currency that everybody wants to have a majority hold over because that's going to get their team, for lack of better terms, to win. The erosion of trust in public health, the erosion of trust in institutions, the erosion of trust in medicine and science is a very, very deep issue. But I fear that even the word trust is becoming as meaningless as the term misinformation because we're using it in a way that I don't think actually gets to the core of the issue. We can't just tell people, trust the science or trust the experts or don't trust these people. I would actually like to pivot the conversation to worthiness of trust. Like, who is worthy of your trust? Who has deserved that trust? And am I doing things or am I saying things that make me a trustworthy messenger? Because it can't just be looked at as just this thing that exists or this thing that should be demanded from a population.
Do you see social media playing a role in building that trustworthiness?
I do, because that's where a lot of people are. It's not the only place that people are, but I do think that a lot of trust erosion happened on social media. I also think a lot of trust building is happening and has happened too. So, I talk a lot about the goodness of social media. There's so much bad. There's so much darkness. I have experienced vitriol that we could talk for hours about. But I also have seen transformation where the sense making of science communication, the empathy in science communication, this is actually the explanation that I was waiting for, these aha moments that happen, have actually connected dots for people and said, oh, I can trust public health, or I can trust this person who works for this institution of public health, et cetera. I don't think it's going to happen overnight. I think that this process of rebuilding and repairing is going to take many, many, many years. But I also don't think it's one way to do it. I think trust is going to happen in a very relational way, too. It's not just going to be through content. It's not just going to be through SciComm online. A lot of it is going to come from talking to your doctor, talking to your community members, talking to people who you do trust to share information in a reliable way.
As a leader in the social media space, there's a lot of people out there that are doing what you do, trying to do what you do. They are out there fighting the algorithm, putting out good information. Can you give them some words of wisdom?
Yeah, I mean, I'm so encouraged by the number of people who have entered the space and joined the good fight of being good messengers and sense makers on the internet. It's not for the faint. So I always want to say, in the encouragement, there's also a moment of take care of yourself, because this is very harrowing work. But my encouragement is that the good outweighs the bad. I know this. I've in my most crude assessments of my DMs and in my kind of more careful reads and actually trying to categorize the data, there's so much data in my DMs, I know that the good outweighs the bad. And I know that there are meaningful transformations happening in people's understanding of science and people's understanding of health that are helping them make better choices. I do think that there is a very loud minority of folks that take up a lot of space because they are putting that salacious content that we talked about. And then I also recognize that we're in a situation where a lot of this work is unfunded. This is I do this in my extra time. I'm unpaid. I do it with my two thumbs. I don't have a team creating content with me. And that can be very hard because this should be paid work. A lot of it is just unpaid labor. And so I want to be very transparent about that too, because it feels like it may have a high ROI if people are looking at things like follower count or opportunities. A lot of it is not glamorous.
But it is hopeful. Jessica Malaty Rivera, thank you so much for joining us on Public Health on Call.
Of course. Thanks so much for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.